Okay, well, we're going to get started. Good evening, and welcome to the Autism 200 summer series. And during our summer series at the Autism 200, we focus on topics around autism and topics impacting adults. This is our adult summer series. My name is Katrina Davis, and I'm a family advocate at the Seattle Children's Autism Center. I'm also the parent of a 20-year-old young man with autism. This presentation is being streamed via Facebook Live, so we average quite a few views, thousands really, each time we do these series. So we welcome our large cybernetic audience tonight, as well as you folks in the room. Tonight's presentation will be viewable online at Seattle Children's Facebook, YouTube, and Children's website. So just, be aware of that as you ask questions or make comments, that your comments or questions will live on forever online. So keep that in mind. And there will be a Q&A portion after the presentation tonight. Tonight's presentation is a topic that keeps parents like me up at night. We know that people with developmental disabilities, including autism, are at an increased risk of abuse and neglect. The population also appears to be an increased risk of exposure to trauma and violence in childhood, which can produce lasting effects. At the same time, post-traumatic stress can be very difficult to detect and treat among developmentally disabled or autistic adults. This presentation tonight will outline primary risks, as well as recommendations for assessment and treatment of trauma and neglect in adults with autism and intellectual and developmental disability. Our instructor this evening is Rachel Lofton. Dr. Lofton is a clinical and school psychologist who specializes in autism spectrum disorder. She has extensive experience in diagnosis, assessment, and intervention to help promote positive outcomes for people with autism. In addition to her clinical work, Dr. Lofton has been involved in cases involving special education, family, criminal, and civil law. She has a particular expertise working with people with autism, intellectual disability, and other conditions that increase social vulnerability and complicate interactions with law enforcement. Dr. Lofton's clinical research interests include interventions to increase independent function in young adults, strategies for increasing self-monitoring, transition to adulthood, sexuality, education, and sexual identity in people with ASD. Dr. Lofton is an adjunct faculty at the Psychiatry and Behavioral Sciences Department at Northwestern University's Feinberg School of Medicine and in the Psychiatry Department at the Yale School of Medicine. I met Dr. Lofton not too long ago at a training about a year ago, and I speak on behalf of my colleagues in the autism world. She's a skilled, caring, energetic, and dedicated professional, an impressive advocate, and really a good human being. The autism community is fortunate to have you, your passion and your expertise. We welcome you to the Northwest and to Seattle. I'm going to turn it over to Dr. Rachel Lofton for tonight's presentation, Abuse and Neglect of Adults with Developmental Disability and Autism.
Thank you, Katrina. That was a really sweet introduction. I appreciate it. I want to add just a couple of little things about my background that have relevance to the topic that I'm going to be talking about. When I was first out of college, I worked for a little while for the Department of Child and Family Services in Los Angeles, so DCFS, or Child Protective Services. So there is a little bit that I might draw on from that, and I just wanted you to know kind of where I'm coming from with that. And as Katrina mentioned, I do often work with people with autism who have gotten in trouble for doing things that may have hurt others. But what we're focused on tonight is far and away the bigger issue, and that is people with autism being at risk of being harmed by others. So I'm really excited to be able to talk about this topic, especially in the hopes that we can move forward toward prevention of abuse and neglect in this population. I want to make a couple caveats too, and one of those is that this is a really big topic, and I will not be able to be as thorough as I'd like. I cannot be comprehensive in my review of abuse and neglect, right? Those are really massive topics. But I hope to kind of pull out some themes, initiate some thoughts, and focus a lot on the questions that the audience may have and how I can be most useful in giving you the specific information that you'd like to get. Thank you. Oh, I didn't push my button.
It's up.
Thank you. Thanks. Okay, so just to start with an overview of what I plan to cover tonight, I will give a little bit of data. You're going to hear me say a lot that there aren't many data available. There's not a lot of information, but I'll talk about what there is. I want to speak about specific vulnerabilities that may exist among people with autism and developmental disabilities that may make abuse and neglect more likely. I want to speak very specifically about trauma in autism and what that might look like. A little bit about prevention, a little bit about treatment, but a whole lot about how we need more research and we need more information to inform prevention and treatment. So I think it makes the most sense to start by defining a couple of the terms that I'll be using. You'll see ID on a lot of slides, and I'm using that to mean intellectual disabilities. And this just refers to cognitive disability, somebody who may have trouble with more conceptual kinds of thinking, may have trouble with self-help skills and require a higher level of assistance. ASD is the shorthand for autism spectrum disorder, referring to people who have been diagnosed with autism. Trauma, kind of a catch-all phrase, meaning someone who has had an event that they perceive as traumatic. That may be something that other people don't think should have been traumatic or something that doesn't seem traumatic to other people, but something that is experienced by a person as trauma. Trauma-related psychopathology. This is kind of a catch-all phrase to refer to trauma symptoms that may or may not rise all the way to the level of post-traumatic stress disorder. And then the next one is post-traumatic stress disorder, or PTSD, and that's a DSM-5 term that refers to a collection of symptoms that someone may experience after having a traumatic event or series of traumatic events. Abuse. And abuse may include physical, emotional, or sexual abuse. So when I use that term, sometimes I'll specify, but in some studies it's more vague, and I may use it more vaguely as well. And then finally, neglect. And for those of you who don't know, neglect is simply when someone's needs are not met by their caregiver, or they're put into situations where medically, psychologically, or other caregiving roles are just not fulfilled, which affect that person's life and outcomes. Okay, so this is the first time when I tell you that little is known, and as I said, I'm going to say that a few times. But when we look at the data on abuse and neglect, we don't know a lot that's really specific to autism and adults with autism. There are some things we know, but not a whole lot. A lot of what people write about and discuss is extrapolated from broader developmental disabilities research or from pediatric autism research. So they look at what do we know about abuse and neglect with kids and how might that apply in adults. And to be honest, even there, even among kids with autism, we don't know a whole lot. So it's still an early kind of developing area for research. A couple things we do know, though, that I think are really important to say off the bat. One is that underreporting of abuse and neglect is a major problem in this population. Stigma is a factor. Of course, when we talk about something like sexual abuse, everyone thinks about stigma, and they're aware that the person who's being abused or even others in the family might not report it because of the because of the stigma we have in society when we think about sexuality and sexual abuse. But there's also a lot of stigma when it comes to reporting other kinds of abuse and neglect. If you think about who's closest to your family and knows most about what happens with you day to day, those are people who have an interest in protecting your family and making sure that you look good to the outside, right? So there's going to be a reluctance to report concerns about emotional treatment, about the physical treatment of people within the family. Does that make sense? Okay, so that underreporting can be a very, very significant factor because of that stigma. Also the case that a person with autism who's being abused may not report it him or herself because they don't recognize what is abuse and what isn't. They may not understand the difference between just being mean and really abusing someone. That's a fine line for a lot of us to get, and if you have a social disability like autism, it can be an even more difficult thing to understand. And that's particularly true when we talk about things like sexual abuse that are very complicated social interactions, right? So it can be very difficult for a person on the spectrum to detect what crosses the line. And then I think perhaps the most obvious reason that abuse and neglect are underreported, they're often very significant communication barriers. So if a person has expressive language deficits, they may not simply be able to report the abuse that they need to report. And unfortunately, that same communication deficit may make them a more likely target because the person who's abusing them knows that they won't be able to report. So that's a significant factor as well. Now, within intellectual disabilities, there's a range of rates presented in the literature for the rates of sexual assault. Consistently, though, they're reported to be quite high. So sexual assault, just in a few studies I looked at, the range is something like 25 to 60% of people with intellectual disability have been victims of sexual assault. And because of this, many sexuality education programs for people with intellectual disability are primarily focused on boundaries and prevention of sexual assault, which is fantastic in that we want people to be protected and we want them to have their needs met. But the cost of that is that they're focusing only on prevention and there's a loss of instructions. The same people then don't have as much of a chance to learn about healthy sexuality and development of relationships. So it's kind of a cost benefit there. Also in intellectual disabilities, in adults with intellectual disabilities, the risk for physical abuse is significantly higher than it is in a general population. Within autism, we're going to break down the specific data a little bit more in a minute. But one thing I want to point out within autism is that some people on the spectrum are much more susceptible than others. And one, I think, very clear example of this is a study that came out a couple years ago that found that high schoolers who had autism as well as a mood disorder, 90% of them had experienced a significant trauma in their lives. However, people who are on the spectrum but did not have a mood disorder, only 40% of those had experienced a significant trauma. So that's a very huge difference. So just the addition of that mood disorder made them so much more susceptible to having the trauma. We'll talk in a minute about why that is. It's a complicated relationship with a lot of things happening. Some other bits about autism that I think are really important to understand. Most of the studies that have been done up until the last few years were really focused on bullying. So a lot of people were looking at bullying, and pretty much everybody found that there's a much higher rate of bullying in autism than there is in the typically developing population. What's a little more mixed are the results when they look at, are there more referrals to child protective services? Is there a higher incidence of maltreatment? It's a little more mixed. So many studies found, yes, indeed, there are more in autism, and others found that there weren't. But what seems to be pretty consistent is the finding that individuals who have autism have had more extended and more frequent psychiatric hospitalizations. They've had more law enforcement encounters. And both of those things can contribute to trauma. If you think about what happens in a psychiatric hospitalization, many people who are hospitalized are removed from their family, they're removed from what they're used to, they're removed from their routines, and some of them even require or end up getting restraints, seclusion, other methods used to maintain behavior that could be pretty traumatizing for a child. Likewise, interactions with law enforcement. Those can go smoothly, those could be pleasant, of course, but often they're terrifying, and often they're very unexpected. And one thing we know about autism is things that are unexpected, things that aren't predictable are more likely to induce panic, more likely to be scary, and ultimately more likely to be traumatizing. Something that's kind of interesting that I wasn't aware of until I was preparing for this talk is that in autism, there's a higher likelihood of trauma-related psychopathology. And I'll talk more about this in a minute in a really interesting way that they started to look at this. But it appears that when people with autism experience the same phenomenon that a typically developing person experiences, an individual with autism is going to be more likely to be traumatized by that situation than a typically developing person. So we'll talk more about that in a minute. But finally, I think a really key point when we think about the data that exists for trauma and autism is that PTSD, or post-traumatic stress disorder, and autism are very rarely diagnosed in the same individual. And one of the main reasons that may be is because people who specialize in trauma usually know very little about ASD. People who specialize in ASD often know very little about trauma, right? So we know about our specialties, but you don't get the same people who really understand both. And it's quite likely that if an autism specialist like me were to see a child, we would chalk a bunch of the symptoms that we see up to autism. Those same symptoms, if a trauma expert's seeing them, they might say, oh, that's trauma, that's trauma, that's trauma. Both people are doing their jobs the best way they know how, but you don't have the expertise on both sides in order to make a complete and accurate diagnosis. Okay, there's one huge study I want to talk about in autism, and this is a population-based study of maltreatment in kids. The author in all of these studies I reference are in my reference page that's at the end of this talk, but the author is McDonnell, and this is from 2018. And I think one interesting finding is, in this huge population study, kids with only autism were more likely than the general population to experience abuse. People with ASD plus intellectual disability were even more likely. But then the biggest category for experiencing abuse was people with intellectual disability. So it's interesting to me how those kind of pieced apart in that way. People who had intellectual disability, even with or without autism, were 2 or 3 times more likely to be maltreated than others in the study. Physical neglect across the board was more likely in anybody who had a developmental disability. But then that ASD-only group, they were the most likely to experience physical abuse. So it really seems like the way a person presents, the way they interact with another person, has some impact on how they are maltreated if they are maltreated. But all of this, any kind of maltreatment along with one of these diagnoses, was associated with increases in problem behaviors for the child. So there was more aggression, there was more hyperactivity, and there was more trauma. So within ASD, what makes trauma more likely? That's a question that we don't have a really good answer for yet. So some of the studies are hypothesizing a couple of things. One is saying an older age puts someone at more risk for trauma. Some are saying that lower IQ, which might fit with what we were saying earlier about communication, because lower IQ tends to come with poorer communicative ability, but we don't know. And then finally, there's a hypothesis that the gender, so having a male gender, is a risk factor. Not so sure about that one because we've historically had trouble identifying females as having autism, and so we haven't quite necessarily captured that accurately, so I don't know how right any of these data are, but these are some of the hypotheses that people have, that within autism, these could be further risk factors. So what does trauma look like? First, I want to talk about an intellectual disability, and then we'll be more specific in autism. This is what's tricky. Trauma and intellectual disability looks a whole lot like some behaviors that can just come with intellectual disability alone. So one of the first things that researchers talk about is oppositional behavior. Oppositional behavior means refusing to do things that someone's telling you to do. You might not say no, but you might just not go along with it. You might be less cooperative. Physical aggression, right? Harming oneself, demonstrating sexualized behaviors, And then less frequently in the intellectually disabled population, but still present, are signs of anxiety. That might look like pacing, that might look like nail biting. For a nonverbal individual, you really have to kind of read those physical symptoms more to try to get a sense of whether anxiety is present. And then if we're talking about autism alone, so somebody who has autism but does not have intellectual disability, there certainly are more intrusive thoughts, more distressing memories. They may lose interest in doing things that used to be enjoyable for them. Irritability increases, and lethargy, so just less energy to do the things that they may have wanted to do before. A lot of those symptoms overlap with the symptoms of depression, which can further make it more difficult to kind of tease apart diagnosis and kind of tell what's happening. There really hasn't been found in the research literature a difference in symptoms when it comes to symptoms like fear, anger, in some other areas. It's tricky. There's a big question about whether exposure to trauma also increases that individual with autism's risk for violence. There's one very well-written argument that was published in a psychiatric journal that suggests it does. And it makes some sense. And if you look at case studies where someone with autism has committed a violent act, there very often is a trauma, or there is something in the background. But we haven't done the kind of studies that need to be done to definitively say that that's true. So far people are making associations, but we don't yet have the research to support that idea. Okay, so why specifically would people with intellectual disability and autism be at risk? Well, part of it is that idea of developmental disability. People who have a developmental disability have a chronological age, so their actual age, right, that you tell people, is much higher than where they're functioning socially. There's a big gap there. And that makes them very vulnerable for people treating them like their chronological age when they're really not ready for that. They're not thinking like that. They're not behaving like that. That's particularly true for sexual abuse, right? Imagine a girl, a young woman who's 19 but has a significant developmental disability. She may be functioning like a 12 or 13-year-old. For someone to have intercourse with her, to try to date her, to be sexual or romantic with her, unless they also have a significant developmental disability, that may be really tricky. That might constitute sexual abuse, right? It would depend on the situation and the circumstances, but you can see how that developmental delay there has an impact. We talked already about this, but I think it's important to mention again, difficulty with expressive communication is a huge, huge reason that people on the spectrum and people with developmental delays are at risk. This means that they're not able to say what's happened to them. And even many verbal adults, many people who can answer questions and give you certain kinds of information, can't share a whole anecdote about what happened. They can't tell you an entire situation from their day. So they're much more likely to have difficulty reporting if something like this were to happen. The social disability is a big piece of it. We also alluded to this earlier when we talked about they might not realize that something constitutes abuse. So a typically developing 18-year-old knows if they're getting hit, if they're getting kicked, if they're getting pushed by a caregiver, that that's wrong and that's something that they can report and they can get help with. Somebody with a developmental delay may not know that, likely doesn't know that. And as we already talked about, if it's something like sexual abuse, it's even more complicated and even more complex social behavior. So the likelihood that it would be recognized is much lower. This is where I want to come back and tell you that really interesting piece about how people with autism may be more sensitive to trauma, might have a bigger trauma response. There was a study that looked at responses after an earthquake. So 6 months after an earthquake and a year after the earthquake, they followed up and did an assessment. And they found that the people with autism had a significant decline in their self-help skills after the earthquake and had much more difficulty than the typically developing population. So that's a different kind of trauma, right? That's not abuse or neglect, but it's exposure to a really traumatic experience, a really terrifying experience. And the people with autism were showing a differential response to that particular trauma. The other risk factor that I think is important to highlight is that individuals with developmental delays may have a lot more caregivers and adults who are in positions to interact with them intimately. So they may need assistance in the bathroom. They may need assistance with dressing, showering. All of those situations make the likelihood of inappropriate contact more likely. They offer opportunities that might not be present for those people who don't need someone to assist them in that manner. When it comes to things like physical abuse, individuals with autism who have self-injurious behaviors, or some people with developmental disorders are very clumsy or have awkward motor movements, and they may end up bruising themselves or having marks on their bodies because of that. So that could really cover injuries that may have been committed by another person. Or that could be offered as a story, a cover story by a caregiver who had actually inflicted an injury. And the last one is suggested in the literature that families who are coping and working and raising somebody with a developmental disability may be under more stress. They may have an environment where there may be more domestic violence, where there may be more family stressors. And we know that family stressors, people don't want to be mean to their kids necessarily, but sometimes family stressors bring out an anger response or an overreaction or a situation that over time, with lots of other compounding factors, may result in trauma. There is in the literature just a beautiful, very complicated visual to talk about the complicated interaction between a number of factors. And I wanted to give you a visual to talk about it. So I made a very simplified, not very pretty, not really great colors, but a simplified version of that, kind of to help us think about it. So what the original, very fancy visual showed is the complex interaction between the core features of autism, exposure to trauma, and then trauma pathology that a person shows. And the reason I wanted to put this up here is it's not a simple relationship. It's not simply that a person is exposed to trauma and then shows trauma pathology. I mean, that's part of it. But actually what happens is that very trauma pathology makes the person more likely to experience more trauma, right? So we talked about how some of the trauma symptoms might include aggressiveness, right, and some problem behaviors, some behaviors that might cause the person, not saying that this is right, but it might cause a person to be in a situation to be yelled at, to be put in a seclusion or put in a restraint, so that that cycle can start to kind of repeat itself. Some research is also indicating that some of the core features of autism are also playing into that, that if exposed to traumatic events, the core features of autism, meaning the social communication deficits that are part of autism, may actually get worse if a person is withdrawing or showing some of those depression-like symptoms that we talked about earlier. That can also contribute, so that this cycle doesn't just become a linear, straightforward one, but a very complex interaction. In trauma-related psychopathology here, that I'm referring to with the green, it includes things like having very poor emotion regulation, so that reactions to situations are heightened and much bigger than they might normally be for the individual. Along with that comes really high levels of cortisol or stress hormone, and then the fight or flight combination of symptoms all together, which worsens emotion regulation further, right? So when future stressors come up, there's that big panic response again, and it all kind of can cycle around and around. Does that make sense? It's a lot kind of happening. It's very messy, and this graphic doesn't do it justice, but it's a lot clearer than trying to see the other one that does a much better justice. Okay. So specifically, we talked earlier about how post-traumatic stress disorder isn't often diagnosed in autism, and I gave you some reasons why. And a big one is really just that it's difficult to assess because so many of the things that are PTSD can just look like autism. So when we've tried to take very common symptom measures that we use in autism spectrum disorder and give it to people who have trauma, we can get some really high false negatives and false positives. And the same thing happens in the other way. If we take a PTSD measure and we try to give it to people with autism, we get a lot of false negatives and false positives. So the existing instruments don't work very well to go from one population to the other. It's not like you could just give somebody a rating scale and arrive at an accurate diagnosis. It's got to be a much more complicated assessment process. Part of the problem is when we talk with people in order to diagnose post-traumatic stress disorder, we're really requiring them to tell stories and talk about their internal experience, talk about things that are happening inside their body and inside their own heads. And it's very, very complicated and difficult for most people on the spectrum, most people with intellectual disabilities to do that. Some of the symptoms are clearer than others. There are people who have autism who get post-traumatic stress disorder and have very clear nightmares and very clear phases of re-experiencing the trauma, and there's a clear-cut diagnosis. But for most people, it's a lot more complex than that and not quite so clear-cut. One really tricky thing is that the official diagnostic criteria for post-traumatic stress disorder require a traumatic event. And most of us think of things like the earthquake I talked about, or, I'm from Chicago, we saw somebody on the block get shot. Those are the traumatic events that you hear about in a clinic, right? However, for a person with autism, there can be different traumatic events that have that same very significant response within the body, that huge stress response that happens within the body that wouldn't be recognized by another person who doesn't know that person exceptionally well. So it could be something that other people just don't expect to have as big of impact. I have like a million examples from people I've done therapy with over the years going through my head where the family moved houses. The family got a new couch. The family got rid of a favorite stuffed animal or something where life had changed and there was a difference, which might be difficult for a lot of kids, but wouldn't really be traumatic. But in autism, some of those things that we might perceive as minor really can have this bigger traumatic reaction. There are some really cool, promising tools. The one I cite here, the Hoover and Romero, is an app that I think ultimately will be a really neat thing that we can use to look more accurately at autism, but they are not yet well validated. And this is true. I was just having this conversation about an hour ago. This is true in other areas of autism too. We're starting to have these tools and ways to assess different things, but we just don't have the research we need to say that they absolutely work and absolutely are the right things to do. Okay. Now I'm going to turn a little bit to talk about prevention. And so I want to focus the prevention aspect a bit more on the sexuality piece. And I'm doing that because, frankly, talking about physical abuse, emotional abuse, and neglect are just too big. And without kind of narrowing it down, I think we'd be really stuck about where to even start. So with prevention, I want to talk about education and supervision. I see those as two of the main components that are necessary to prevent sexual abuse. So with regard to education, when I do sexuality education talks, the things I like to stress are teaching facts, which this is what happens in sex ed. They teach facts. This is the anatomy. These are the acts. These are the sexually transmitted infections. You know, we're pretty good at teaching facts to people. But the social aspects and the why don't get covered as much. So what that refers to is, for social aspects, what are the relationship aspects? What does it take to be comfortable with someone who is allowed to touch you in certain ways? What do you want to have happen for you romantically and intimately? And what are the sequence of events that lead to that, right? And teaching that in a very frank and direct way. The why, I think, is really interesting because it's a part that's often neglected. We're so often telling kids, you know, do this, don't do this. But what we often don't cover is why it's important. What are the social reasons that we do or don't do certain things? So often if I'm teaching this topic, you know, we'll have conversations. Sometimes we have to talk about, why does somebody want to date? Why would someone want to report sexual abuse? You know, in breaking down, and really any concept that you're trying to teach, the social aspects of explaining why those social aspects are important. And then with regard to the education piece and how to teach it, I think this will be apparent to any of you who regularly spend time with people with autism, but it's extremely important to be concrete and direct, to be very clear, to be very factual, to not be judgmental. And I keep hammering on this when I present, even though I think it's obvious, because when we talk about sexuality and we do sex ed, we have a real tendency to resort to using metaphors or hinting at things or not fully explaining and being as direct as we need to be. And I think that's true even when we're talking to kids who don't have any communication deficits. But in particular, if we're talking to young adults who have social problems and may have significant communication problems, we owe it to them to be as clear and direct as we need to be in order to get the information across. Okay. With regard to the supervision piece, I really highlight internet safety here, because I think when I talk to parents, this seems to emerge as one of the biggest worries. And when I talk to teachers as well, how can I keep kids safe when they're on the internet? There are predators. How can you navigate that? And so being safe on the internet, I really see as kind of the intersection of teaching a young adult or a child how to regulate what they're doing and regulate their own behaviors, and also how to avoid and manage risks, right? So it's the balance of those two factors. And then really the way to start to get at that, first is scaffolding. And what scaffolding means is it means providing the level of support that the individual requires, but gradually pulling it away as that person develops. So in a minute, I'm going to go through with you like how you could potentially do that. And then the way to teaching about avoiding and managing risks is through education. So providing that education like, yeah, this is something that happens in the world. This is something that happens in the world. And then helping the individual see, what do you want to have happen for you? And what's the route to get there? If what you want to have happen for you is healthy, safe relationships with other people, this is the path that you need to take to get there. So helping educate them to get where they want to be. Okay, so with regard to scaffolding, this is pulled largely from the American Academy of Pediatric Guidelines. They don't call it scaffolding, but it's their guide for screens and screen time. I'm not going to go through all this, but what I want to point out is once you get to about 6, they don't really have specific guidelines anymore. So they're very clear that really young kids just do not need screen time. They need very little, if any. But what do you do after 6? What should families really do? And one thing I think is really important, from the time the child's going online, so you're ultimately, you're thinking about when this person's 30, how do I want them to be able to manage themselves? What do I want them to be able to do? You need to be thinking about that difference that we already talked about. Where are they chronologically and where are they developmentally? Quite often parents will say to me, yeah, but he's 17. He needs to be able to go online. I can't be watching everything he does. And that's true, and I understand that. And when you have a young adult, they have rights, and they need the independence. But at the same time, if that 17-year-old has the social development of 11 or 12-year-old, they aren't safe online. There are some guidelines and some structure that have to be put into place. So one of the things I'm going to talk through, we're going to start at a younger age, but I want you to keep in mind that this is a developmental age that we're talking about, not a chronological age, right? What I propose here is very flexible. It should be adjusted to fit the needs of the individual, but it really is removing very gradually the level of supervision, scaffolding very carefully so that the person learns what's safe, so that they have that oversight, so that when they do make mistakes in what they're doing online, they get that feedback and they can talk it through with a parent and get constructive information. One of the things you'll notice up until a person is developmentally about 16 to 18 years old, I recommend keeping most screens in a really central area of the house, right? Because that aids in the supervision. And then gradually removing the search options, and so that ideally before a person is out and launched on their own, be it at a chronological age of 18 or a chronological age of 35, that they've really learned how to do this and that they've learned to be safe. And the point of that isn't, to make a nanny state and have somebody constantly watching over the shoulder, but it is to kind of shed light in these dark areas and corners, because unfortunately things can often happen online that no one's aware of, and no one's kind of looking into and paying attention to. So kind of putting a light on those areas and bringing them into awareness can be really helpful. Back to thinking very specifically about trauma and trauma-related psychopathology, there's not a lot of evidence yet, there's not a lot of research yet about what the most effective treatments are, but what is out there really is focused on either modified versions of cognitive behavioral therapy or modified versions of even more specific cognitive behavioral therapy that's called trauma-focused cognitive behavioral therapy. Cognitive behavioral therapy, in general, is a treatment approach that we recommend in autism when someone needs to if someone needs help with anxiety or depression or other core psychiatric issues like that. Cognitive behavioral therapy is often our go-to approach, our go-to technique. The problem is it doesn't really work for everyone with autism because it does require a certain level of being able to reflect on your own experience, report your own experience, recognizing your emotions, recognizing your own thoughts. There's a lot we can do with modifying it, and we can reach many, many more people than we could if we didn't modify it, but there's still a substantial number of people with autism who still can't quite get there. There is also evidence in the research literature that we can teach really specific conflict resolution skills, and that can be helpful for kids who have exposure to trauma and trauma-related psychopathology. Then we can also teach really specific social communication skills to help them better relate to others and improve their interactions with others after they've had these things happen. A very behavioral approach can sometimes be effective too. Now, this isn't something that I saw in the research literature, but often when people with autism have had a bad experience somewhere, this could be like what you would consider a low-grade trauma, maybe not anything like PTSD, but just something they want to avoid, something they don't want to go back to. Something like exposure with response prevention or other behavioral strategies can be helpful to kind of get them back into those routines and get them back doing those things that they used to do. And what that is it's just a behavioral therapy that exposes them to incremental steps toward getting back into that thing. So that each step by itself isn't that painful, and eventually they get there, and they're able to get there without the avoidance. So that's where the response prevention comes in. They're not allowed to avoid anymore. They kind of have to put themselves into those situations and get back to doing it. And I emphasize the incremental piece because, of course, if we know a situation has been traumatic for somebody, we would never want to just force them directly back into it. Just a lot more research is needed, as we already talked about. We need better prevalence data and a better understanding of how trauma really is impacting this population. And in particular, we need that data so that we can see how to use that toward prevention strategies and prevention approaches. As we already talked about, there are some promising measures for assessing PTSD and autism, but we need to assess those and see if they are going to hold up and be really good measures of those symptoms in this population. And then treatment studies. There are a few out there, but we certainly need more and need to better understand what's there. You will see slides for resources and references. And then also the final slide has my contact information if you have specific questions that we're not able to address in today's session. I'm happy to respond to things over email as well. And I understand that we're going to have, I'll leave that last one up, that we have questions that we can take from the room as well as questions that may be coming in over Facebook. So I'll go ahead and transition for that.
We don't have anything on social yet. So
Okay.
Start pushing the resources you had in the previous slide. I'm going to send all of the links out to each one of those on Facebook.
Thank you.
Questions in the room? Any questions in the room before we turn it over to folks online? Comments, questions? Things that maybe you wanted to address today that weren't? Well, I had a comment or a question actually when you talked about autism and aggression, and that if someone is exposed to abuse or trauma, are they more likely to be violent? And whenever there's a mass shooting, I just hold my breath hoping that we're not going to hear that the person was autistic, because I know that that's the stereotype. And it's scary as a parent and as someone who loves people that are autistic, what the perceptions are around people with autism being scary and violent, when really they're more likely to be on the receiving end of abuse and neglect and violence as opposed to the perpetrator. So any thoughts about that?
I think you're exactly right that people with autism are at a much greater risk of, as we already said, bullying, abuse, neglect, being on the receiving end of violence. There is unfortunately a small subset of people with autism who have the potential to be very violent, and I think it's really unfortunate that the media focuses so much on them. And I think it's also unfortunate because it receives so much attention and so much thought, whereas the more common problem of aggression in autism is much more one of somebody who might react because they're hypersensitive to sensory stimulation, or they have a desire to do something a certain way and they get interrupted and they lash out emotionally without thinking, not in a planful kind of violent way. But I don't think that kind of violence gets the same amount of attention, yet it's far more common and impacting families all the time.
Exactly. So if behavior is communication and our loved ones are acting out behaviors, that's where a treatment and focus needs to be, because when behavior sometimes and aggression is the disability, and we don't treat it as a disability, we treat it as bad behavior and maybe even criminal, unfortunately. Yeah.
Yeah. Oh, absolutely. And yeah, that's a key for really thinking of behavior as communication, understanding what is this person trying to tell me? What does he need to communicate? And then the most effective thing we have, in my opinion, for treating that kind of aggression is functional communication training. So putting those communication strategies in place that can give somebody a more effective and efficient way to communicate.
Exactly. So when you're saying treatment, you're not talking about taking that away, but more replacing it with ways to communicate. So yeah, that's what's in need. Thank you.
Right.
Well, I blabbered there a little bit. Does anybody have any other thoughts or things they want to say? Okay, is this a question?
Yes.
Okay.
Question.
All right.
I will have a little background.
Yes, please. Okay.
When my son was in high school. He stopped doing his homework, and I found out he had been bullied.
Oh,
And so and this is before he was formally diagnosed with autism, but he was everything else but he has autism at level 2. I looked and looked around for a psychologist. I talked to special ed teachers, starting with the preschool teacher and on up, and I found a psychologist. But the interesting thing is, he really wasn't. He was not a specialist in autism, and my son wouldn't talk to him. So he says, "Well, this is not going to help." What type of psychologist or such or therapist would one look for if your child has gone through bullying and other forms of abuse?
yeah. Oh, that's a great question. So the question about what kind of therapist do you look for? First, I want to highlight something you said that I think is really fantastic. And you pulled out the fact that there was an abrupt behavior change. And that was, even though you didn't immediately know it was bullying, that was your first indication that something was different. And that is one thing that I should have highlighted more in the presentation, that we often see significant behavior changes in autism. That doesn't always mean there's abuse or neglect or anything, but as a caregiver, you want to be sensitive to that and know that it is potentially one of the things that could be going on. So a very significant change like that, really great to highlight. Your other question, or your main question though, is difficult because so much depends on an individual. There are people who have expertise in cognitive behavioral therapy and are thoughtful, patient people who understand how to adapt to where someone is, and may have no training in autism, and they may end up doing pretty well if they get some guidance and get some support. On the other hand, there are people who know a whole lot about autism but haven't had good therapy training and just aren't really as much therapists. So I don't have like one down and dirty quick answer, but I think it's important as a parent or as the individual yourself to talk to potential therapists and see how that match feels. And then also ask specific questions like, what kinds of therapies have you been trained in? What do you think the right approach is here? And you want a knowledgeable, specific answer to that question. You don't want to hear something really loosey-goosey, kind of willy-nilly. Thanks. Gary?
Thanks for excellent presentation. As a provider that works with children, but also focusing more on adult population, I think your numbers of how common trauma is, I think is really good for myself and for other providers to remember that, because often we're presented in situations where a person is having an increase in symptoms or regression in function, and I think having it within our differential needs to be there. You and I were talking before the talk about screening, and I find it difficult in the clinical setting to feel like I'm effectively screening and ruling out the possibility of trauma, especially sexual abuse, especially in situations with adults with intellectual disability who are often coming with both parent and caregivers that are not the parents to the session. Any pearls of wisdom, caveats, thoughts that could help providers and families in the situation on how to kind of screen for these issues?
Sure. Thanks. That's a great question. One thing I've found helpful, it's actually really, really tough to pull off, practically speaking, but speaking to as many of the collateral contacts as you can is sometimes really helpful, because you may get one impression from talking to parents, but when you talk to school or you talk to the job coach, you get a totally different point of view that can kind of bring the whole picture together. So I would suggest, in addition to carefully interviewing the way you normally would, the more support other people in the circles around the individual you can speak to, the better. I found that there have been a couple of things that have come together where we knew something significant changed. And even parents were talking to the transition program, but until I called and I talked, I didn't really get the full story and the full picture. And sometimes, even if a caregiver is really involved, staff may be cautious in what they tell a parent or how they report it. So sometimes you as a third party, kind of putting yourself in there and making those calls, you can get that additional information. But it's very hard to do in the real world.
Okay. We've got a few questions trickling in. But we're waiting to see anybody else have any thoughts. Okay, come on over there.
My question is, you mentioned it there, if there's an abrupt change in a person who has ADA, ASD, in their behavior, sometimes it can indicate some level of abuse, but not all the time.
Right.
Is there research on the percentage of the amount of times that it is abuse occurring versus it was just maybe some other issue?
Not that I'm aware of. And what we would normally do when there's an abrupt change is first rule out a lot of the other common things that happen. So in someone, especially someone who's nonverbal, if there's a sudden, abrupt behavior change, there are a lot of medical things to rule out. Gastrointestinal issues, an ear infection. I've had a few guys with an impacted tooth that nobody knew about. So there are a lot of things like that that you would want to work with your kid's physician and really make sure that those are ruled out. And that coupled with talking to all the people, like I was saying, I think tends to be the best way to rule out other potential causes for changes. The difficult thing is, though, sometimes in autism there are changes that we just cannot pinpoint why they've happened.
And then if you are able to rule out other things, or you're able to pinpoint some level of trauma that did occur, how do you address that in students who are less verbal or nonverbal?
Normally what you would want to do, and again, I'm not aware of much literature on this. I'm really going off of my clinical experience to answer this question. Normally what I would want to do is I would want to focus on how it's impacting that person day to day and look at those specific situations, the places where maybe they're not doing things they used to enjoy, or whatever it is that's changed, and how can we help in those very specific places in those very specific situations. And often if you can bring someone back to their usual routines and get them back into some of their old habits, they will feel a lot more comfortable, and a lot of other things will fall into place.
And then what do you do to get all providers, like you said, talking to everyone on the same page?
I mean, if I could figure that out. If you're able, and you have, let's say your child's in a transition program, if you're able to get them to schedule quarterly meetings where you sit down as a group and talk things through, that's what absolutely should be happening. I know that can be, again, very hard to pull off in the real world. Sometimes you have a more central person, like an individual therapist or a school social worker, who can kind of be a point person who reaches out and coordinates a lot of other people. That's less desirable. And sometimes it's the parent, him or herself, who's doing all of that. It's less desirable because you don't have everybody talking to each other, but at least then all of the information is still getting shared.
Okay, thank you.
Yeah, thank you for the question.
Okay, I have one question about, so we've been talking a lot about individuals that are autistic that are maybe limited, nonverbal, or severe communication deficits where they can't speak for themselves or share what's happening in a way that we can understand. We might read their behavior as communication, but we don't know what's going on really. What about the section of the spectrum and the wide spectrum that it is, folks who are very verbal and can express themselves or maybe have that ability to share what happened? Is there any benefit that you know of about them maybe working with other people on the spectrum for support? Like we as parents, we hang out together and get support. Do people with autism or autistics hang out and get support when it comes to trauma? Is that helpful?
I'm not aware of any research on that particular topic. I do know that, that more verbal population, the people who are able to reflect, are the ones who have participated in the CBT studies and the trauma-focused CBT studies. So that's certainly an approach. There are some studies in typically developing populations that look at group approaches to that. So potentially, sure, but nothing I'm aware of in the research literature.
We do. So this question comes in from Colin. He is tuning in online, and he would like to know what the abuse neglect statistics are, specifically or more particularly for criminal charges against disabled individuals.
Yeah, and I'm sorry, off the top of my head, I don't know. Oops, I just pushed a button. I don't know specifically what those statistics are.
Do you know where, if there's research on, or if there might be places he
One
could
study
go
I would
look?
suggest checking out is the McDonald study there from 2018. So that is, again, that's that population-based sample that looks at the rates of maltreatment. And that is in children. It's not with adults, but that's our best proxy to kind of approximate that I'm aware of. There may be something else.
Thank you so much. I'll share that link with him.
Thanks.
Ideas on making the community more aware. What are some ideas to make the community more aware?
The question was, what are some ideas to make the community more aware? It's tricky because I think most of us who do a lot with people with autism, who do a lot with intellectual disabilities, are somewhat aware. Like it's on our minds that this is a vulnerable population. This is something we need to be worried about. But as the comment we had over here, for those of us who are in this day to day, sometimes we do forget. And we forget that this needs to be on our rule out list, and it needs to be something that we're thinking through. I don't think as parents you probably ever forget. I think it's probably something that you are always worried about and thinking of. But I think caregivers going into environments and asking, what's the supervision like? Who else is in the bathroom when he's in the bathroom? Who has access to this? And then asking those specific questions that worry you. Not only does that satisfy the question, your own curiosity and wanting to make sure your child is safe, but it also brings it to the attention of those caregivers who would never think of hurting another child, but it also might not have occurred to them that their coworkers could. And it does get everybody feeling more accountable and everybody thinking about it. So that's one thing I would suggest, that all of us continue to ask those questions and be thoughtful about it. As clinicians, I think, keeping it on our list of things that we rule out and things that we ask specifically about is very important. And then I think as parents, being that advocate and asking those tough questions, even if it makes people uncomfortable, is important.
I will throw out a quick resource here in line with this. We have a local resource, the ARC of King County here, that it just started a sexual or healthy relationships curriculum.
Yes.
And the good news is, as much of what you said that makes up a good program, they offer, and they pay attention to that. So we do have a good resource. It's the ARC of King County. It's the Healthy Relationships Curriculum, and it's for teens and adults.
Some of the other local ARC around the country have that as well. And I don't know whether the national ARC does, but that's a great, thanks, Katrina. Thanks for sharing that.
Your answer for the previous question actually covered it, but I'll just ask again, and if Carol is listening with us. So Carol asked, are there any resources, programs available for teaching people with autism about sexual abuse and safety? And that
There is one I'll throw out too.
Another one? Okay.
Actually, a couple are listed here that I really like. So on my slide, it's very general to mention Planned Parenthood, but what really impresses me about them, even though it's most of their resources target typically developing people, when they talk about what are the points to teach in sex education, they really hit on a lot of these social aspects. So the more complicated social aspects are there. And then the Davies and Dubie curriculum, it's a few years old now, but for more verbally adept, typically, intellectually intact population, like that's a really good resource for them. It's got a lot of great activities and ways to teach different pieces of information. But again, I want to encourage people, as much as I've probably terrified parents with this information, I just want to emphasize teaching about how to have a healthy sexual relationship is critical. And if you teach, just as we would want to teach what are the appropriate communication skills to go out and have less aggression, how to have appropriate social relationships, even intimate relationships, is protecting against sexual abuse as well, potentially, because you're teaching what you can expect from other people and how you need to treat other people.
One of the barriers might be parents not going there with their kids, just avoiding it.
Sure.
Because with the typical kids, they do that, but also with, and even more probably with people with intellectual disability and autism. We're just too afraid to talk about it. And really, we're doing a disservice if we don't. Yeah.
Well, and so many parents will see, oh, he still has so many childish interests. How could he possibly also be interested in sex? The other thing is, if you have a kid who has a lot of complex needs, you've got 20 other things to get to today. So I see how it easily can fall off a list. Absolutely. So not something to beat yourself up about, but something that still maybe keep on the horizon.
And my son is part of the antisocial social club, and he does not like to go into groups at all as strangers. His anxiety just goes through the roof.
Yeah.
That's a problem.
So that was a comment about a particular son who just isn't social, which is a totally different problem, but yeah, that can certainly happen.
Going back to the safety component of people with ASD being arrested, things like that.
Yes.
Are we doing a disservice by teaching our kids how to navigate healthy relationships so much that we're focusing only on that we're not teaching the entire community? It's kind of annoying
Yep.
just going into the grocery store or police officers not knowing, things like
Yep. So that question, she wasn't Mike, so I just want to repeat it, was about, are we doing a disservice by focusing on teaching our individuals with autism how to behave appropriately in the community, but we're not teaching the community about autism? And it certainly is not an either-or proposition. We absolutely have to improve those things in the community. And I've done training with law enforcement and other groups like that, and I think that's absolutely critical. And just coming back to that law enforcement question, one thing I do when I work with patients who are likely to have a run-in with law enforcement, so basically anybody over about 12 or 13, I make sure they have these cards I keep in my office that are bright yellow that say, I have autism. And they're taught to keep that with their ID. So if a police officer ever asks for your ID, you're handing over both things at the same time. Because already, if a person with autism is behaving differently, that puts them at risk if the officer doesn't understand autism. People may not be able to see you on camera, but you're a woman of color. So if you have a child of color, they're even at greater risk, as we know, when interacting with law enforcement. So that absolutely is critical. And I would suggest if you don't have something like that, maybe getting it.
I know from my own experience, there are a number of those sample cards online. If you just Google autism emergency wallet card,
Yeah.
or,
we have cards.
yeah,
I mean,
yeah,
our
yeah.
cards is completely
Yeah.
identifiable just because of
Great.
stickers we have around, but it's still a problem.
Yeah, a card alone is not going to take care of the situation. Absolutely not. But it's, again, a little piece.
In the review of the literature, has anybody looked at gender differences with regards to being victimized? Both male and female at risk at similar rates, or it just hasn't been studied well enough?
So there were, some of the older studies would point to being male is a higher risk, and I think that there's a problem with that, and I think it's because they're comparing it with a typical population, but when you've got males identified at such a higher rate, I think there's an issue there. There may be something that I didn't see, but I haven't seen anything newer with better ascertainment.
Is there a difference in functioning abilities as far as having more safety issues than kids who maybe are a little bit higher functioning? Or people who are
So that was a question about whether an individual's level of function puts them at more risk for safety issues, right? I think that's a complicated question, because on the surface, I think, having difficulty communicating oneself is a big risk factor that might put someone at more risk. So in that instance, you would think somebody with more classic signs of autism would be at more risk. One study I haven't seen that I would like to see is when they look very specifically at some aspects of social function and social awareness, because sometimes you can have someone who's got a very high IQ and very high verbal ability who just doesn't have the social wherewithal to kind of detect when things are happening. This might get back to what we talked about at the very beginning. There's a type of vulnerability that can happen in the higher functioning adults that I haven't seen any studies on. Maybe they exist, but I've had a lot of patients who have had money taken from them. I've seen a lot of people in jail who basically got tricked into doing something because somebody talked them into it. I've seen people who, met a woman once for a date and she just moved in with them. So these situations where people are really vulnerable to being taken advantage of because of their social disability. And I think it'd be interesting to know more about that, because I imagine that's a very significant risk factor as well.
So one of the things that I was asking about related to, in my mind, what the question about gender differences is kind of related to this question, because I can't remember where I saw it, but a suggestion that females were at higher risk, and I had kind of thinking that through, was thinking about how often, and again, this is a general statement, so
Right.
obviously there's variation, but often females will have a higher social interest, but then their social skill may be less.
Yes.
And so then, because of the social interest, will often then attach into a group of people without recognizing the
Yes.
risk. And I think we get very worried about this, about kind of online forums, especially, but also in person as well.
Yeah, and anecdotally, I've seen it happen over and over that I've worked with young women who are very interested in having social contacts and make social relationships and put themselves in situations where they're at great risk for sexual assault and have in many cases unfortunately been sexually assaulted. However, it gets so complicated because the reporting rates for women tend to be higher than the reporting rates for men. And I don't, frankly, it's not my area, so I don't understand enough about it to really tease apart the data. Yeah.
I should follow that up with, rather than just, I'm not wanting to scare everybody. I think the highlight again, what to do is, it comes back to, I think, the importance of open discussions and education, right?
Yep.
And being very direct and frank in education, around these topics.
And supervision. And unfortunately, I think a lot of parents have kids who get to the point that they're old enough to go out and date, and they're tired, and they've been doing this a long time, and even though they might feel inclined to supervise or even realize there's a risk, they kind of let things happen against their better judgment. And I think a lot of times it's important to trust your better judgment, while also at the same time respecting that, you may be you have an adult in your house who has their own rights and their own autonomy, and it can be very hard to manage their risk with their need and right to autonomy.
Okay, so I think we're near the end. If we don't have any more questions or comments, we'd like to thank you again for this presentation tonight, and Dr. Loft can stay after if you have any comments or questions, and if any other questions come in. But thank you so much for that powerful presentation tonight.
Thanks for having me.